G'day and welcome to another episode of Endo Untangled. We are coming to you from the 2026 Australian POTS Foundation annual conference. We're very excited to be joined today by Dr Alexis Cutchens, who is an international guest here at the conference. She is a board-certified cardiologist and is recognised globally for her clinical expertise in the diagnosis and management of POTS, MCAS and EDS hypermobility. Alexis Cutchens, welcome to the podcast.
Thank you so much. I'm so happy to be here.
We're genuinely really thrilled to have you here because your area of expertise is something that in Australia, in the sort of work that we are doing, it is actually really hard to find experts to discuss some of these incredibly complex topics. Thank you for your time and expertise in joining us.
Of course.
As you might know, we work in endometriosis and pelvic pain, and I say this to patients a lot. I felt like when we took on this work, we were going to be working a lot with gynecology and doing a lot of work around the endometriosis, which we do. What I wasn't expecting is that I would have to upskill in POTS, MCAS and EDS because it seems to be such a big part of so much of what we see. What I'd love to talk to you about today is about MCAS. And we see people, they've got bladder issues, they've got gut issues, they've got bloating, they've got pain, they've got fatigue. Absolutely multifactorial. However, MCAS is probably part of it. Can you tell us a bit about MCAS, what it is and when we should be thinking about it?
Sure. As you've realized, there's a huge overlap between MCAS and endometriosis. And, I touched on this a little bit in my talks, but we see lots of mast cells in that ectopic endometrial tissue, and there's just a huge amount of overlap. So MCAS is an abnormally functioning mast cell. Usually the mast cells are just like extra twitchy, or they degranulate easier than a normal mast cell. The mast cell is your first line of defense against pathogens. So I explain it this way: if you eat poison, the mast cell is what makes you vomit and have diarrhea to eliminate the poison from your GI tract. So the mast cell is that initial cell that gives you that alarm that is trying to get rid of whatever the toxin is. So when the mast cell is not working properly, then you could have the same response to foods, for instance, that aren't poison. You can have weird responses to different things that you put into your GI tract, but the mast cells are everywhere. So you can, they line your sinuses, your lungs, your GI tract, your genitourinary system. And so they can be triggered in any way in any of these places. And the triggers are endless. Traditionally, mast cells are what produce histamine and other cytokines in response to an allergic reaction, so an IgE-mediated allergic reaction. But we know
be like
now,
an anaphylaxis type of thing at
Exactly.
worst. Yeah, IgE being immediate.
Exactly, at
release.
its worst, right? But they don't. It used to be thought they only responded to IgE. I had a professor of mine who was from medical school who was talking to me about this process, not recently, in the last couple of years, and he was like, "But the mast cells only respond to IgE." And I was like, "Well, no, that's not true. They respond to so many things," and he couldn't. He had been teaching about IgE-mediated responses for his whole career, and he's not young. And this was totally new to him, right? So it's not well understood. We don't have a lot of information about mast cell dysfunction and their triggers to things that are other than IgE, but this definitely exists, right? So so that's kind of the concept of MCAS and what it is. And then, the next kind of question is, well, who has it and why do people have it, right? So I see it in my patients with POTS. But those patients also have hypermobility spectrum disorders. They have endometriosis. They have venous compression syndromes and vascular congestion. So they have a lot of other associated pathology going on that can not only drive MCAS and mast cell disorders, but be associated with it in a way that you see them overlap.
it's so overwhelming, and it sounds like we're seeing lots of people, lots of sort of shared symptoms and complexity in the patients that we see. It's interesting that that you're seeing this and working with this as a cardiologist,
right?
And I'm a primary care doctor. I'm a GP. And so in some ways it's more comfortable for me because I'm used to sort of sitting across all these different sort of specialties. I have to ask, before we sort of dig more into this, how did you get into this area as a cardiologist?
Yeah, I get asked that a lot.
Okay, I can imagine.
So I guess POTS is very it has there are a lot of symptoms that go along with it. And as a cardiologist, I started taking care of patients with POTS when I didn't learn anything about POTS when I was in medical school, when I was in residency, fellowship. I was not trained in POTS. But when I started as a faculty member at my first job, there were women coming in to see me for palpitations and passing out, and they were telling me, I think I have POTS. And I was like, what's POTS? I don't know what that is. I had to go Google it, right?
Oh, I had to do that too.
Yeah. And I had to ask my colleague who was sitting in the other room typing his note from his previous patient, like, what is this? And I happened to ask a colleague who is very well versed in POTS, and he was probably the only one at the academic institution I was at who believed POTS was real and understood these patients. So I don't know what would have happened if I had asked someone else.
Yeah, if
right?
they said, nah, it's not a thing.
Yeah,
They're just anxious.
Exactly. Like what path would I have taken? It would have been very different, right? So anyway, in taking care of patients with POTS, you realize that there's a lot of stuff going on. I had a patient once come back to me and tell me, I was diagnosed with mast cell activation syndrome. I was put on a medication called Xolair, and I stopped all of my medications for POTS. Like, she was on a medication to help lower her heart rate, a medication to bring up her blood pressure, and I was like, well, what is this MCAS thing, and why did those treatments stop your POTS? I mean, this is great. I'm struggling with all these POTS patients. Maybe this is the answer. So I started asking patients about allergy symptoms. Do you get rashes? Do you have, chronic sinusitis? Do you have GI symptoms? And everyone is telling
that would be
me, yes,
everybody.
Yes.
Yeah.
And so I started sending my patients to the allergist. And I was like, well, there's this thing called MCAS. Go see the allergist. Maybe they can help you with it. Maybe you can get on this drug called Xolair and get cured. It would be great. And then a couple of months later, the patients would come back to see me, and they would say, the allergist that I saw told me that they thought you were crazy. I mean, the allergists were literally telling patients that I was like off my rocker and that MCAS didn't exist and that I was doing a disservice.
Ouch.
Yeah.
Ouch.
Yeah. And so
for you and your patient.
Yeah. So I was like, oh, I had no idea. What do you mean?
I didn't know I was crazy.
I didn't know. I was like, yeah. Why wouldn't I send them to the allergist, right? I mean, I'm a cardiologist. Why should I be doing that, right?
How did you respond to that? Like, what did you do?
I just took it on myself. I learned how to take care of MCAS. I mean, and then I started figuring out what Xolair was for, why was it prescribed, and all these other biologics, but it's used for chronic idiopathic urticaria and chronic spontaneous urticaria. So then I'd start asking patients about that. Do you get hives when you're, in the cold or in the sun, or do you have, weird hives that pop up for no reason? And when they told me that, then I sent them back to the allergist and I said, ask them to treat you for idiopathic urticaria. I didn't, and don't say anything about MCAS. So that's how I got around it. But I did, have a couple conversations with allergists. I asked them, like, how high can I go with the antihistamines? Can I really give patients 40 milligrams of cetirizine a day? Is it okay? And they're like, oh, yeah, we do that all the time. No problem. Go for it. Like, they were happy for me to be treating patients in this way because they didn't want to do it. And so, and then I started learning more. COVID came along. It seemed like more and more patients were having rashes and allergy symptoms. Some of my patients had seen, one of my patients had seen Dr. Afrin in New York, who's, the mast cell expert. And so she came back and told me about her experience. I looked at his website. I was like, who's this Larry Afrin guy? I have no idea who this is. And I called up my friend Peter Rowe, who's at Johns Hopkins. And I asked him, I was like, what do you think about MCAS and who's Dr. Afrin? And Peter Rowe said, oh, it's absolutely 100% real. I treat all my patients for it. You have to, join our group that talks about MCAS. I'll introduce you to Dr. Afrin. Boom, 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 right? So then I get put into this group called the Masterminds, which is super helpful, and learned. It was funny. It's a listserv, and I got onto this listserv. This was, I don't know, 5 years ago maybe, and Dr. Afrin had oriented me to the listserv, and he said, you can go back and look at all the different posts that were made. I literally spent the weekend reading. From start to finish, every single question that had come up, every single answer, and it made me realize that these were like the people that got me. I mean, these were these doctors that were taking care of patients were the same kind of person that I am, which was very comforting. Because here I am sitting here taking care of POTS patients. No one else does it. No one else knows what MCAS is, right? I'm just like trying to do it all on my own. And so it was really nice. So that was the story of how I got into MCAS.
And did that deep dive start to put some puzzle pieces together?
For sure. Yeah. Yeah. I mean, they're asking questions, POTS is coming up, and, people are asking questions about, different drugs for MCAS. What can I use for? And it was just, it made me realize that a lot of what I was already doing was treating MCAS in a way that I didn't realize, like calcium channel blockers or mast cell stabilizers and things like that. So the deep dive was very helpful. And I felt like I finally kind of had a group of people that I could use as a resource, which was incredible. So
is this another diagnosis for these people? Are all of these things linked? Or what are your thoughts on that? Can you comment on, because as Alicia said, we look after endometriosis, pelvic pain syndrome people that's kind of have dysautonomia or POTS, and potentially we're now thinking MCAS and EDS and hypermobility, connective tissue, the connective tissue disorders. How is all this linked?
I think it's all the same. I mean, I think there's a huge overlap. I think it's all the same thing. It's not, obviously we have different names for different aspects of this overarching syndrome. I think that it's all connected through an underlying connective tissue disorder process. And so if you have that, and that could mean you're hypermobile, it could mean you're extra stiff, it could mean you have lipedema, it could mean, so many things, but you have some abnormality of your connective tissue, and that's also causing an immune dysregulation. And that underlying problem is what's driving MCAS and endometriosis and, all this other recurrent infections, immune deficiency, autoimmune disease, it's all linked together. So I think it's all chronic fatigue. I think it's all one thing. But we're coming at it. Everyone has their own perspective because we're all coming at it from a different subspecialty. You guys are coming at it from endometriosis. I'm coming at it from POTS. But the reality is we're all treating the same thing.
It's just like a big, giant overlapping syndrome. Dr. Cutchens, I would love to hear, what are the symptoms of MCAS where you're starting to think, I need to be considering this as part of the diagnosis?
Yeah, so in my clinic, essentially if you have POTS, you have MCAS. In my, this is what I believe. So tachycardia is a symptom of MCAS. Labile blood pressure is a symptom of MCAS. These are the ones that I take from a cardiovascular standpoint. Coronary vasospasm, so non-obstructive coronary disease causing chest pain is a symptom of MCAS. I mean, those mast cells degranulate and cause coronary vasospasm, and then you get chest pain. So in the world of cardiology, there's already overlap. But I always ask patients, do you have, seasonal allergies or allergies to anything? And usually they say, yeah, my whole life I've had allergies. Or they say that, ever since I was a little kid, I had really bad allergies. I went to the allergist. They desensitized me. I took the allergy shots or whatever. I mean, usually there's a substantial allergy history. Then I ask about rashes. What kind of rashes do you get? Do you have a sensitivity to adhesive? Can you not wear a Band-Aid? That's pretty typical stuff. I ask about bug bites. That's a big one. If you get a big welt from a mosquito bite, that is pretty typical of MCAS. And, I think about the bug bites, the venom, the insect venom stuff. I mean, that's a big one. But, there are people out there that don't get bug bites, and there are people that do get bug bites. And I think everyone's getting bug bites, mosquito bites, let's say, but it's just some people have an allergy to the venom and they get what appears to be a bug bite versus some people who don't and they're getting the mosquito bite, but they're not actually just having a welt from it, right? So bug bite, reactions, and some people get these enormous, welts from bug bites, and that's a whole nother story. And then I ask about temperature dysregulation, and these are things that people normally consider are POTS kind of symptoms, like excessive sweating or no sweating or heat intolerance. And I think of them as MCAS symptoms personally, because when I treat MCAS, those go away. So I think they're all on the spectrum of this mast cell-mediated autonomic dysfunction. So in my world, in my world, it kind of, in my clinic, I see patients for POTS. I mean, I have patients who come in who don't have POTS at this point because they all know that I do kind of a variety of things. But if you have POTS, you have MCAS.
Can I ask, if you have POTS, you have MCAS. If you have hypermobility, do you have MCAS? What do you think the overlap is there?
So I think so. And as I said, everything's on a spectrum, right? So maybe your MCAS is just, like a little bit of hay fever or a headache every once in a while, or you have a sensitivity to perfumes, but that's it, So it's like, I just don't want anyone wearing perfume around me, but otherwise you have no major stuff going on. So yes, I think you can have this spectrum of kind of allergy type symptoms without hypermobility. But then the question is it MCAS or is it an IgE mediated allergy that's just, I
was going to ask about bowel and bladder. Or
sores in the mouth. That's a big one.
Bowel and bladder symptoms?
Yes. Interstitial cystitis can be mast cell mediated, urinary frequency, and then GI symptoms like diarrhea and constipation can both be MCAS, but bloating is a big one if you have and that kind of overlaps also with histamine intolerance. So, yeah, it hits everywhere.
And you mentioned in your lecture earlier about vulval pain.
Yes,
and
vulvodynia and vaginal pain, burning, irritation, neuropathic stuff.
It's like everything we see.
I know.
I think the trickiest thing is all of those symptoms could be MCAS, but then some of it could be driven by other things.
How much of an impact does significant hormonal changes across the lifespan, like adolescence and perimenopause, menopause, does that have an impact on mast cells and symptoms?
Huge. So, menopause, at least in the U.S., I don't know how it is here, is having this huge moment, right? And there's a lot of talk about perimenopause and menopause treatment of these, taking down the Women's Health Initiative and all the badness that came with that, and which is great. This is what we need as women, and the world is going to be a better place for hormone replacement. People are going to live longer, et cetera. But you see, these people talking about perimenopause and all the symptoms of perimenopause, right? And it's like ear itching and, like mouth burning and, all of these symptoms that are totally
my brain just exploding here as a GP and all the things that I see.
Right. It's MCAS, in my opinion.
I feel like I'm actually going to burst into tears, actually. Do you ever have a moment as a doctor, and I feel like I have these increasingly, where I think, have I accidentally, and I have a good relationship with my patients, but sometimes I think, have I accidentally been just gaslighting a whole lot of people? Not being like there's nothing wrong with you, but not understanding or not being able to know why someone's...
I don't think you're gaslighting. I think it's just... I think it's just... putting these things together, right? And then there's this whole, so I think it's the fluctuations in hormones. Okay, so estrogen is a mast cell trigger, progesterone is a mast cell stabilizer. So literally speaking, if you put a mast cell in a dish and you hit it with estrogen, it'll degranulate. But if you hit it with progesterone, it doesn't change. But in the body...
What does that mean for the patient?
So, well, when the mast cell degranulates, that's when it spews its contents. So it's secreting histamine and cytokines and, prostaglandins, leukotrienes, all these things that disrupt our ecosystem as a body, right? And so that's what causes the tachycardia or the blood pressure surge or the itching in the ear, And so, in my experience, it's the fluctuation in the estrogen and the progesterone that really causes a disruption in the mast cell. It's not necessarily the level. So you can have patients, I have POTS patients who feel like, let's take the case of pregnancy, right? What I tell my patients with pregnancy is 50% of patients feel better, 50% feel worse. The ones that feel better, I think, are responding to that stabilization of hormones. We know that estrogen gets really, really high, but you're not having a monthly cycle. So it's staying high, but it's staying high in a place where it's not bothering you in any way, right? I also have patients who do really badly in pregnancy, and I think that's, it depends, but hyperemesis and I think are mast cell-driven processes. And I think that they, because if you think about the treatment for hyperemesis, it's like antihistamines.
Yes, it is.
Right? And so, right? And it's like, why are we giving these women antihistamines for their nausea and vomiting? It's like, well.
Yes, that's amazing. The other little kind of aha moment I just had there when you were talking about mast cells have a role with prostaglandins. So mast cells increase prostaglandins.
Yeah.
And prostaglandins drive pelvic floor, cramping and dysfunction. Dr. Tanaka June, who is also from the United States, who's a urogynecologist, beautifully said, prostaglandins are hot sauce for your pelvic floor, which helps to explain why there can be so much cyclical pelvic floor pain and just overall pain that our patients get. And you think, well, if mast cells are driving the prostaglandins, then perhaps it does have a role in some of the musculoskeletal pain which we see. And I'm sure it's more complex than that. But
yeah, no, I think it's real. And I think mast cells are also, one of the normal functions of mast cells is initiation of menstruation. So the mast cells get triggered by the fluctuations in estrogen and progesterone to release enzymes that degrade the tissue lining of the uterus to shed the lining. So it's the mast cell that's intimately involved in that process. And you can imagine that when you have menorrhagia and these other, that the mast cell is intimately related with that. Mast cells also secrete heparin. And so they can cause extra heavy bleeding and longer bleeding cycles or whatever it might be. They're sitting right there on the lining of the uterus.
The mast cells.
Yeah.
And of course, heparin being a blood thinner.
Yeah.
And one of the things that makes me think about whether or not someone's hypermobile when I'm first getting their history or when Cherie's getting their history in our clinic is if they're telling me that they're a super menstruator, if they're a super bleeder, I'm thinking, I bet you're hypermobile, but perhaps I should also be thinking...
You have MCAS.
Yeah.
Yes, but also you're thinking you have endometriosis, and also you should be thinking you might have pelvic venous disease, right?
Yes.
So there are a lot of things that cause heavy menstruation, but they're all things that occur in the same population of patients.
Yes, they do. Yes.
And so maybe we're thinking about 5 different things, but it's actually one thing.
Yes.
As we discussed earlier, right?
Yes. And one of the things that I was taught in medical schools, and I'm sure you were as well, is around Occam's razor and that approach of medicine to really think critically about what's coming in front of you and think, is there not 9 things coming in front of you? It's just one thing with multiple different manifestations.
Right.
And unfortunately, and I know you would see it too because you were talking about fragmentation in your lecture, is that we'll see people who do genuinely get 10 different diagnoses and they've seen 10 different non-GP specialists about it and all sorts of other people, and it just becomes a horrible mess for everybody, and it is just awful to see, and we see it all the time. It's heartbreaking and it's just terrible. So I just wanted to mention that.
I think there's a bit of a failure of medicine at the moment, in managing this population of patients, and it's not intentional, but this is how we were trained. I was trained as a cardiologist to never take care of a POTS patient, for sure. I mean, no one told me about POTS. I had no idea what it was. And I didn't go into cardiology to take care of this population of patients. I enjoyed the procedures and the ICU and the, the variety of things I could do during the week and my relationship with patients. And, I chose it for specific reasons. And the ability to it's very gratifying to be able to fix someone pretty instantly. Cardiology is a lot of really cool components.
It's a bit sexy,
yeah.
Cardiology, isn't it?
Yeah.
It's sexy. And I guess my impression of it and going through my studies was, and this is obviously not where you've ended up with your career, is it seemed quite mechanical in the way, and the heart and the cardiovascular system, it's pipes, it's a pump.
Yeah.
That might be why it didn't appeal to me very much, because it seemed very mechanical, and I like sort of much
cerebral kind of things.
Yes, but interesting for you to have gone into this, what's been thought of as this quiet, pump situation, and then just be blown into this incredible complexity, which is just mind-blowing.
It's weird, right? And that's why I don't think you see cardiologists in this space.
Yes, because I
do think it doesn't matter what I was going to go into. So when I was in medical school, when I started medical school, I thought I was going to be a surgeon or an OBGYN. I very much wanted to do procedures and work with my hands and, operate. I spent a month with an OBGYN to try to decide what this was in my 4th year. I was deciding between internal medicine and OB. And I spent a month with her. And at the end of the month, she said, you need to go into internal medicine. And I was kind of shocked. I mean, I'd never been... for every single rotation that I'd ever done in medical school, everyone, I never had any negative feedback. Not that this was negative, but I was kind of like, oh, okay.
What do you mean? You don't want me?
Yeah. And she's like, you just ask way too many questions. I was like, you're right. Yes. Okay.
Although ironically, you probably would have ended up doing the same work.
So then I think, so in internal medicine in the U.S., you do 3 years of this and you kind of rotate through all these different subspecialties, and you can decide to become an internist, or you can go on to further training, which is what I did in cardiology. But I liked everything. Like, I really thought I was going to do rheumatology, then I liked nephrology, then pulm critical care. I mean, it was like I liked it all. I chose cardiology for specific reasons that I stated earlier, but I think no matter where I would have gone, I would have been taking care of this population of patients. So if I had been a neurologist, I would be the headache migraine specialist. And if I was a gynecologist, I'd be doing pelvic pain, right? And, these are the doctors that maybe are more curious or more are looking to take care of a population of patients who don't have answers. And I think that's why I became a doctor, so that I could help people who aren't being helped, right? So I would have done this regardless. It just happened to be that I went through the cardiology, path.
Amazing. I wanted to sort of steer back towards endometriosis for a moment, because I think you probably, as a cardiologist, have some interesting insights for us. You mentioned earlier around how endometriotic tissue, that endometrial-like tissue that can be outside the uterus in endometriosis, is just a mast cell haven, and almost like there's a collection of mast cells that could be driving problems there, and people feel better when it's cut if it's removed, although it's not a cure, because if you've got mast cell activation syndrome, it's still going to be there.
Yeah.
And you can't surge your way out of this problem. But what I'm interested in is, how could we know with our biopsies if they are being removed? Is there a way that we can look at them under the microscope that might help us?
Yeah. So you can stain mast cells with CD117. That's a dye marker, that you can use on pathology to look for mast cells. We usually look for number of mast cells per high-powered field, so anything greater than 20 is probably abnormal. This is kind of a loose measurement because we don't really have a lot of data on normals. Anyone getting scoped is kind of not necessarily normal, although, there are ways, I'm sure, colonoscopy, whatever, but if you're doing routine colonoscopies and there's no biopsies to be taken, then that's a perfectly healthy colon, then, what are we comparing to, right? Mm-hmm. So, but it is one thing to look for and one way to look, and I think it's important for people who are excising endometrial tissue to look for it and see, so we can get some data, so we can get some information and ask questions about MCAS and then correlate those two things, right?
Yes.
But what I find interesting about endometriosis, and maybe you guys can answer this question for me, it's incidentally found right? And no pain whatsoever. People like have normal periods. There's no symptoms. So you can just have it and not have any symptoms. You can have it as a cause of infertility, but again, asymptomatic. And then you go in and you find it and you take it out and then you can conceive, right? Mm-hmm. So I don't know if the mast cell activation overlap has something to do with the pain, heavy periods, dysmenorrhea, like psychological components, fatigue, all the other stuff that goes along with endometriosis, or if it's something else. But there is that component, right?
I mean, the other thing that I see is that I can see someone with all of the symptoms, exactly the same as someone with endometriosis, and have exactly the same symptoms and have no endometriosis
right, but
at all.
That's where the overlap of pelvic venous disease comes into play.
Okay, let's talk about that. I'd love to talk about that.
Because there's a huge overlap. Yeah. There was a study that looked at patients with pelvic congestion syndrome. 60% of them had endometriosis. That's just one study. I mean, I don't think a lot of people are looking at this. So, we have limited data, but I think there's a huge overlap. And I have plenty of patients who come to see me for their POTS, and I ask them about pelvic pain, and they tell me they have all kinds of pelvic pain and that they have endometriosis, and they had excision surgery, and they still have pelvic pain, and it's still there, and, it didn't go away, and the surgeon said that he or she got everything, right? So that pain is most likely coming from congestion of the pelvis and, something like gonadal vein reflux or left iliac vein compression causing venous congestion of the pelvis and pain. So what is endometriosis pain? Is it is it ectopic tissue or is it pelvic venous disease? I think, or is it both? And I think it can be any of the above, right? So I think that's important to consider.
Could you tell us a little bit more about pelvic congestion syndrome and some of those other conditions?
Yeah. So I started studying pelvic venous disease in patients with POTS because let's back up. I had all these patients with POTS, right? Compression, salt, water. This is first line for POTS. I had one patient come in and tell me, I don't ever want to be on a medicine for POTS. Every time I go on a medicine, I have psychiatric side effects. I'm psychotic and I'm admitted to the hospital. Okay, so this is MCAS, right? When you have that kind of reaction to medications. But I didn't know what MCAS was.
Sorry, could you just say that again?
Yeah, I see patients have psychiatric side effects to medications that shouldn't happen. I mean, when I hear that, I think MCAS immediately. But a lot of, the patients that come in with 20 med allergies, their allergy list is super long, MCAS. They're usually reacting to some filler in the medication. It's not the medication itself, but it's the way it's compounded. I was dealing with this early on in my career when patients would tell me that they had to have brand name Crestor. They would not take rosuvastatin. And I was like, sure, I don't mind writing brand name on the prescription. It doesn't hurt me, but I don't really understand why. Now I completely understand why.
And I just feel so awful for those people who have those things happening, who are really just being labelled as being troublemakers or difficult, whether outwardly or inwardly.
Yeah.
That exists in medicine
a
lot. And I also feel like, unfortunately, is that it's overwhelmingly women who are the ones who are suffering in this way, and also being like, oh, well, that's just you being a bit dramatic or difficult,
right?
Isn't it? And that just is heartbreaking.
Yeah.
But anyway, sorry, continue. We're talking about pelvic.
Okay, so I had this patient who told me she doesn't want to take any medications. I said, fine, no problem. She said, I only eat 4 foods: cucumbers, chicken, rice, and something else. I can't remember what it was. And again, I was like, okay, sure. And she's like, and I wear compression socks, and that's the only way I function. And doing this combination, and I drink lots of fluid and eat lots of salt. And that's how I manage my POTS. And if I do anything different, my POTS is out of control. Okay, I had no idea what mast cell activation syndrome was when she came to my office. She's like, look, I just want a cardiologist. This is it. I just want to explain to you my symptoms in case something comes up and I need a doctor, So she comes in, every 6 months. I see her for a couple of years, and then she tells me the compression's not working anymore. I can't do my job. She was working door-to-door sales. Okay, I can't do my job.
Nightmare.
Yeah. because the compression isn't working anymore. So now I don't know what to do. I said, well, let's look at your leg veins. Let's see if what the compression is doing is actually helping the veins in your legs work better. And so we did an ultrasound of her veins in her legs, and sure enough, she had horrible venous reflux. So lots of venous insufficiency in her legs. She was 25. I sent her to one of our vascular surgeons. I said, can you please do lower extremity ablations, GSV ablations on her? He said, why? She's 25 years old. Like, why would I do that? I was like, well, she has leg pain, and she's, uncomfortable, and they're heavy, and she has POTS that used to respond to compression, and now it doesn't anymore. So maybe doing this would help.
And was there swelling or color changes as well, or was
she
it just
definitely had color changes, no swelling? Yep. And so finally he agreed, and then it took her a while to agree. She was nervous about doing this procedure, which rightfully so. I mean, we don't have data. I wasn't. There's no randomized controlled trial saying that this is helpful in POTS, right? But she did it, and then I didn't see her for months. And I called her and I was like, where have you been? Why haven't you come back?
You're the most awesome doctor, by the way.
and she was like, oh, I don't have POTS anymore. I don't need to see you.
Well, you should have let me know, Mrs. Patient.
I know. Yes. Could you please just
tell me I cured
you? Come back once and tell me that it worked.
Send me a card.
Because, I could use this on other people.
Wow.
So anyway, she told me she didn't have POTS anymore and she was cured and she didn't need to see me. And I was like, oh, great. Okay, that's awesome. So I started looking for it in other people, obviously. I started asking about leg pain and leg symptoms. I started learning more about venous claudication and what the symptoms of venous insufficiency are, et cetera. And it was coming up positive in everyone. Everyone's getting that, Then I was sending them all to the same vascular surgeon. He's like, I don't know why she keeps on sending me, you guys. But sure, if you agree to, having this done, then he started doing these ablations for me, and we were noticing, pretty good results. Not in everyone, but it was working. Certainly wasn't hurting anyone. And so then, but after a while, it was kind of like, well, oh, no, actually, I talked to Dr. Rowe about it. Peter Rowe at Johns Hopkins, again, my buddy. I met him because we had a mutual long COVID patient. This was just after the pandemic started. And so I was talking to him, and this was the first conversation we had, and I was telling him about the lower extremity venous disease and how it was, crazy. Well, sure enough, he's like, I can't believe you're doing this. You're totally onto something. We're looking at pelvic venous congestion in these patients, and we see this too. And you should talk to so-and-so and so-and-so, and you need to start looking at pelvic venous disease. And that's when I started learning about pelvic venous disease. And that's when I talked to Brooke Spencer, and, she started, in our first conversation, she's like, are you kidding me? Half of my patients have POTS and MCAS. I don't know what to do with them, but this is definitely a thing in my clinic. I'm seeing all these patients with pelvic venous congestion, and they all have POTS and MCAS, right? And she was blown away that she was talking to a cardiologist who was even asking patients about pelvic pain,
And how does that weave in, and are there any different symptoms, or again, are we still, how do you know
I think
to
it
look?
weaves in because these patients are hypermobile and they have underlying connective tissue disease, and their veins do not work the same as a normal vein. And so when they pool blood in their veins, the veins dilate, the valves in the veins don't work properly. When they have, normal anatomy for them is causing compression of the left iliac vein against the spine. And this is due to ptosis of organs or...
and ptosis being just like they're droopy.
Drooping organs or...
Because they're stretchy.
Yeah. Everything's stretching over the spine,
And can that be present with sort of not joint hypermobility?
Yeah.
Can we have connective tissue disorder without that?
Yes.
Yes.
And you can get this phenomenon of pelvic venous congestion after multiple pregnancies. You can imagine if you have a huge gravid uterus and it's sitting on top of your pelvic veins, then that can cause varicose veins of the pelvis, and that can contribute. So there are different mechanisms at play, right? But I do think in this population of patients with POTS and MCAS, they have some connective tissue problem, and it's making their veins more susceptible to venous disease. So,
and will an ordinary ultrasound type scan pick this up, or do people need to be scanned in a special way to pick it up?
So for the lower extremity, you have to have an ultrasound that's looking for venous insufficiency or venous reflux. It's not, you can't just look for a DVT. So
of course, yeah.
It's a special study. You have to put that on the order. I'm looking for venous insufficiency, venous reflux. Sometimes you still get a lab that's not really looking. You know, you have to find a place that wants to look. I tell my patients in the U.S., and I don't know how it is here, that they should go to the vein clinic that has like a billboard on the side of the highway that's advertising that they do veins, varicose veins, because those are the guys that are going to diagnose you with venous insufficiency because they want to do the procedure to fix it. And so
that is a bit different here in Australia. The system's quite different.
And so the system's a little different.
But a specialist clinic is where you need to go.
Yeah.
And we certainly do that with our pelvic ultrasounds. We can't just send them anywhere.
Unfortunately, I think in like a vascular surgeon's office, they're going to dismiss a 25-year-old woman coming in for venous insufficiency unless she has an ulcer on her foot that's not healing or, you know, major venous stasis changes on her legs, and these patients don't have that. So I think for you in Australia, it might be difficult to get these things diagnosed. I've looked at ultrasounds.
It's ridiculous, isn't it? It's like, why, as you know, women or people assigned female at birth, like, is it so hard for us to be looked after in a way that we can get good care and diagnosis? And I know. I probably,
and I think it's, you know, a lack of research and a lack of knowledge, and then it's a lack of interest in learning more. You know, and so, so I don't know if the studies are all done properly because I've looked, you know, I know some physicians here and they've asked me to look at studies for them. And I've seen, you know, some studies that are done poorly and they wouldn't really give you a diagnosis of venous insufficiency, for instance. It happens in the U.S. too. I'm not saying it's that you guys are all bad at, you know, diagnosing this. It's not true. But it is a matter of finding the right place. And then for pelvic venous ultrasound or diagnostics, that's hard too. So you need a lab that's actually looking for venous compression that believes it's real in there and not just some incidental finding. And it's true, there are people who have compression of the iliac and renal veins who have no symptoms whatsoever. Okay, so we have to acknowledge that there's a population of patients who are not symptomatic with these things, right? Just like the endometriosis, right? But it should be read as such regardless. There should be some, you know, and it's not always diagnosed, even if it's there. Same goes, so the other testing that we use is an MRV, which is an MRI that is looking at venous phase contrast, similar to an MRA, which is an arterial phase contrast MRI. This is an MRV. And you can see the pelvic veins on that. You can see varicose veins of the pelvis, the pelvic floor. You can see renal vein compression, iliac vein compression, but oftentimes the radiologists don't read it as abnormal.
Do they need to be upright in any way, or if they're lying flat, it will still catch it?
So usually you can see it when they're lying flat on the MRI.
But it's just about, can it be interpreted as that, or is it peaked up?
Right. Well, so when I started doing MRVs, when I was looking for this, I started with ultrasound. No one's had an ultrasound that was abnormal. You know, the patients had very, you know, significant symptoms. So then I asked, well, what do I do next? And Dr. Spencer told me get an MRV. So I'd order the MRV, still normal. So I would send the images to Dr. Spencer and she'd look at it and she's like, let me show you all the abnormalities on this MRI, right? So she taught me how to read them because they were being completely misinterpreted. And so now I know how to do that. But when I asked the radiologists, you know, like why, I don't understand, the head of, you know, body imaging, I was like, I don't understand why the radiologists don't even say anything about it. Like, it's clearly there. And when I'd review the studies with her, she'd agree it's there. And she's like, well, they tell me that they don't want to give a diagnosis to a patient that's going to lead them down the path of an unnecessary procedure.
But that's not their job though, right, isn't it? Their job is just to report on the pictures,
Exactly.
not to make that decision on their behalf.
Yeah. I mean, this is but the radiologist looking at these studies literally didn't want to put this in anyone's head that this could possibly be something that could be contributing to any kind of symptom. It doesn't make sense. Yeah. So that's how you look for it, but you have to have someone who has expertise in interpreting these images so if it comes back normal, it doesn't mean it is. You can't take a negative study as a rule out in this population.
I tend to come back to the patient a lot and think about, okay, what does this mean for a patient? I'm just thinking about someone who's coming into our clinic initially and they've got pelvic pain. They do have all these symptoms. Like it's a big problem. They've got, headaches, fatigue, pelvic pain, all the things that we talk about. And like I think labels are good for understanding, but it's like, where do we start with how do you approach this in terms of, okay, well, we're talking about endometriosis, now we're talking about POTS, now we're talking about connective tissue, pelvic pain, congestion, where do you start and where's the, can you comment on that?
Yeah, it's hard. So, I'm primarily seeing people who are having, difficulty staying upright and a lot of chronic fatigue and a lot of, they can't function, right? And their primary complaint to me is not pelvic pain or, but when I start asking them about pelvic pain, they're like, well, yeah, I mean, I spent days at home every month, right? But that's not why they're coming to see me to begin with. So I usually target kind of the most prevalent symptom first. So I try to manage their POTS. I try to teach them about things they can do for their POTS. I give them medication for their POTS. And then I treat their MCAS. And I try to control that. And then, most of my patients have severe fluctuations in symptoms at the time of their period. So if that's the case, then I work on trying to eliminate that. I'm pretty aggressive with trying to get rid of people's periods.
Look, we do too, where we can. Yeah.
And so, and I understand that there are some nuances there, and it's not always the best thing to put people on birth control and all the stuff. But the reality is, these patients feel so much better, and when they're having a flare in symptoms every single month, then it's very hard to get their POTS under control because you're just. The second they get to a point where they can function, they're not functioning again. And then they have to work their way back to a functional place. And if I can get them so that they can continue work and build on their progress and not have this huge flare every month, then that's what I do, right? And then, someday, once we got everything under control, we can take you off the pill, you can go get pregnant, whatever you want to do, right? But I do feel like stabilizing the hormones is helpful. And then, I send them for evaluation of endometriosis if I think that's what it is, or evaluation of pelvic venous disease if that's what I think it is. Both of them can help. The treatment of both of those can help with POTS.
So since we're here mainly talking about MCAS, although you obviously can't talk about MCAS without talking about POTS and all the other things, when you're looking at starting to manage someone who you think has MCAS, well, actually, if we go back one step from there, do you clinically diagnose MCAS, or are there any particular tests that you look at to try and diagnose them?
So I go by the consensus 2 statement and consensus 2 criteria. And actually, a paper was just published in the last week or so on revisiting consensus 2 criteria 6 years after they put this initial paper out. So I haven't read it yet, but I'm dying to. But anyway, that just came out. And I basically ask a full history. You're looking for multi-system symptoms. So that's part of the diagnosis of MCAS. Then you're looking for response to medication. So one of the criteria that you can kind of click off the list of making a diagnosis of MCAS is, do they respond to antihistamines? Do they have symptomatic relief from a mast cell stabilizer like ketotifen or quercetin or cromolyn? So if that is the case, then that's another check mark for a diagnosis. And then you can look for markers, mediators, these basically the cytokines that mast cells release to confirm the diagnosis. The other way you can confirm is by looking at pathology and staining for CD117. So,
and just quickly, so with that staining, could that be done on, say, a biopsy from a colonoscopy or an endoscopy as well?
Yes.
Yes, okay.
Yeah.
Are there any other tissue samples that you look for? I'm sure you're, as a cardiologist, not biopsying people in different, or are you?
No, I'm not personally doing any of the biopsies. Yeah. I think the most commonly is the GI tract because these patients have so many GI symptoms. They're seeing the gastroenterologist anyway. They're getting the scopes. They're getting the biopsies because they're, concerns about gastritis or esophagitis or whatever. And so that's usually the most common spot that we see the mast cells, and we look for them. But you can look for them in the skin. You can look for them in endometrial tissue, all these other places as well.
And so just getting on to management, obviously everybody that we see is different and needs an individualised approach. And obviously anything we talk about here isn't, I guess, an individualised recommendation.
Right.
But we're lucky on this podcast that we have a lot of GPs who listen to it and other health practitioners, and many of our patients are really interested in self-advocating. Do you have any things that you do first or think about first in terms of management?
Yeah, I put everyone on an H1 and H2 blocker. There are some nuances to that. So we have in the US, we have cetirizine, fexofenadine, loratadine, and then we have levocetirizine, desloratadine. Those are the big ones.
And these are in Australia, your easy to get over-the-counter antihistamines that are non-sedating.
Second generation,
your,
right.
Your
they don't cross the blood.
Claritines, all of those that Zyrtex that people have got, Telfast that you've got in the cupboard, most of us.
Yes.
And do you do that just at the sort of prescribed dose that's on the box, or do you do a higher dose?
So I tell people to start with the prescription dose, which is usually once a day. It's usually this long-acting. Fexofenadine has, the short-acting version and the long-acting, but usually it's the once-a-day dose. I tell patients to take it for 2 weeks, and if their symptoms don't change at all, then to switch to a different antihistamine, because a lot of times patients will respond to one but not another. So they do really well on Claritin, but they don't do well on Zyrtec, or vice versa. So it's important to not just try Zyrtec and Pepcid and then be done. So I tell patients, after a couple of weeks, if you don't feel any different, try a different antihistamine. So that's the H1 blockers. The H2 blockers, I usually start with famotidine. It's just the most available in the U.S., but you guys have ranitidine over the counter here. I saw it in the pharmacy because that's what I do when I go on vacations. I look at drugs.
So
in the pharmacy.
you're a massive nerd like we are.
Yeah, yeah. So I go and check out all the over the counter. Yeah. So you have it, and apparently according to people like Dr. Afrin, it works better than famotidine, but we really haven't had that available in the U.S., and so I haven't been using it, but I think it's a really good option for patients.
Yes, because there'd be a lot of people here who wouldn't have access to someone to prescribe them necessarily.
Right.
What we're talking about is an H2. The ENES, the famotidine, ranitidine. Yeah. And there's another one that I can't remember.
There's cimetidine in the U.S., which is Tagamet. I don't know.
Yes, no, I'm not sure if we've got that. We've got another one. Nizatidine.
Yeah.
Yes.
Yeah.
So they're the H2s, but you're right. Ranitidine is available over the counter in a smaller dose, but might be a good way to try something. So you start with an H1 for a couple of weeks, find one that works for you if you can find one, and then do you add an H2?
Yep. So you want to be on both.
Yep.
The beauty of the H2 is that it crosses the blood-brain barrier, and it's not sedating. So I have patients tell me that their fatigue gets better, their anxiety improves, they sleep better on the H2 blockers. So a lot of people are like, I don't need to take that, I don't have reflux, but it's really doing much more than treating acid reflux. And then just a side note, what's going on social media right now with the H1, H2 blockers treating PMDD and perimenopausal symptoms, this is also very real in terms of mast cell activation syndrome, right?
I mean, you've already mentioned psychiatric type symptoms from mast cells,
Yeah. So that's a side note. But so anyway, I start with the H1, H2 blockers. Those are, remember, only blocking histamine receptors. So they're not doing anything to stabilize the mast cell. There's still histamine swirling around in your bloodstream. There's still other mast cell mediators swirling around in your bloodstream, the prostaglandins, the leukotrienes, all the different cytokines. And so stabilizing the mast cell is important too, because we prefer that it didn't degranulate and spew its contents, right? So you've got the histamine receptor blockers, which help a lot with symptoms, but you want to stabilize the mast cells. So the next thing I add is, the mast cell stabilizers like quercetin and luteolin, which are flavonoids, which help stabilize mast cells. I use ketotifen, which is an H1 blocker, but also a mast cell stabilizer. Cromolyn and
Ketotifen, that's also used for headaches, isn't it, as a headache management?
Yes.
Yeah,
which,
on its own.
Migraine in general, I think, is a mast cell mediated process.
Yes. And the other one, I know I'm getting a bit off topic, but something that I didn't realise for a long time that I use in pelvic pain is amitriptyline, which is
a great mast cell stabilizer, mast cell modulator.
Yeah, and we use that a lot. I use that in my pelvic pain patients, but also in my migraine patients and sleep and all the other things. And
the mechanism.
yeah,
I know.
As well,
It's that really blew my mind when I realised how much of an antihistamine it was, because I'm using it. I think I'm using it for nervous system regulation,
Right.
but I'm actually using it. Or perhaps I'm doing both neuro and immune.
Yeah.
But anyway, just that's my little sort of side topic there. Sorry. So mast cell stabilizers. So ketotifen, and there's cromolyn
sodium. Yes.
I don't think I've ever prescribed it.
It's so safe, and you can use it in all different orifices, right?
Oh, wow. Okay.
So there's intranasal cromolyn, which helps with MCAS-mediated symptoms in your nose. There's inhaled. So it used to be, before albuterol, in like pediatric clinics, they would just do nebulized cromolyn for asthma. It was just all, that was all they had. And then everyone stopped using it because albuterol came along, and it was so much easier, and you could, put
that's
it.
the salbutamol, the sort of puffer. We call it salbutamol. Presumably, we're talking about
Probably
the same
thing.
It's a beta agonist.
Yes.
Yeah.
Yeah. And so, so it kind of like fell off, and no one used it anymore. But actually, I've had patients with chronic cough who have tried everything, and I put them on inhaled cromolyn, and it goes away. So, and a lot of those inhalers have all these other preservatives in them that make the MCAS worse, right?
And one thing I just wanted to say, when you were talking about management options for MCAS, I nearly fell off my chair where you had a slide which you said, you could try this, you could try this, you could try this. But just remember, any of these things also might make it worse.
Yeah, yeah. That's because of the, whatever's in it that you react to.
So we talked about mast cell receptor blocking. We talked about mast cell stabilizers. You mentioned GLPs as well.
Yeah. I use them in micro doses. So I usually use tirzepatide. It seems to be tolerated better.
And that's Mounjaro.
So tirzepatide usually start at 2.5 milligrams weekly, but I use it at 0.25 in my patients.
So a tenth of the starting dose.
Yeah, I do that for a couple of reasons. I think that the MCAS patients in particular are very sensitive to the higher doses. You get more, or POTS patients, more gastroparesis, more constipation than average. And so it upsets the stomach. So you started at a very low dose, but it seems that low dose is also mast cell stabilizing. It has anti-inflammatory effects. There's glucose regulation, which is a whole nother topic in this population of patients, but all of them have PMOS and insulin resistance and glucose intolerance, and they all benefit from glucose stabilization and the anti-inflammatory effects of that. I've started using them more frequently, actually, and more first line, the GLP-1s, because so many people respond so well. And it's really easy to do. And it doesn't go into the GI tract. So many of my patients have so much trouble with medications. If I can give them something that bypasses the GI tract, it actually seems to be beneficial for them.
Yeah. And I often say to my patients, I'm looking for a medication for people where I think they'll have more than one benefit from it, which is where sometimes, not always, but sometimes I'll use amitriptyline because I think if it's going to help you with your sleep and your headaches and your pain and your bloating, then we'll use that.
It's like the original
the
GLP-1, the amitriptyline.
I just want to ask, all of these management strategies, pharmacological, are these safe to use long term? Or are these short term while there's a longer term view here?
So mast cell activation syndrome very much flares, ebbs and flows, flares and then calms down. So I don't think, most of my patients aren't on all of these at once long term. I think there's a lot of question around long-term use of antihistamines because people think they cause dementia. There's no causal relationship that's ever been discovered that a Zyrtec causes dementia. The study was done with diphenhydramine or Benadryl, and they looked at patients who developed dementia. Then they went back and asked them what medications they had taken their whole life, and they were more likely to have taken Benadryl than someone who doesn't have dementia. But it doesn't mean that the Benadryl caused the dementia. It could mean that
it's just an association.
That their allergies predispose them to dementia. And it's possible that taking the Benadryl made the dementia less significant. We have no idea, right? So people get worried about long-term use of antihistamines, and I think there's nothing to worry about. I mean, yes, there's something to worry about with all long-term medication use. We all have to understand that there's risks involved with any medication, right? But if you're bedbound and I give you Claritin, and you can get up and walk your dog again, then why not take the Claritin,
Yeah.
Yes, and with anything, it's always about weighing up the risks and any possible risks versus the benefit. And I agree.
Right.
If you are incredibly debilitated by what's happening, there is also consequences of not doing anything.
Yes.
And they are significant in this group too.
Right.
And not doing anything is significant.
Right.
Yeah, I know, but I just want to ask. I know, Alexis, you're my favourite person in the whole world. And I'm probably going to be obsessively stalking you. But so what? Like, if once everything is kind of getting better, like, what are there lifestyle things? Are there is there anything else that we can do then?
Yeah.
You know, like what we term pillars of health.
Right.
Does that impact any of this? Or
Yeah, so removing triggers is really important. It's probably the first thing I should have said in terms of management of MCAS. I didn't, I kind of jumped right to the medications, and I should have said that if you can remove triggers. So one trigger, for instance, might be tachycardia. And if you give a patient something to lower the heart rate because their POTS is flaring, then that might help their MCAS symptoms, right? So you want to remove triggers. A big trigger is mold. These patients are very allergic or sensitive to mold. So if you have mold in your home, that's something you want to get rid of or, get out of your home. Sometimes I'll send people away on, just go on vacation for a week somewhere where there isn't any mold. Like, make sure to check the Airbnb that doesn't have mold, and see how you feel. And if you feel better in that location than your home, then you need to find whatever it is in your home that's off-gassing or mold or whatever that's causing you to be triggered, right? So removing triggers is important. And that includes foods and, environment. I mean, there's all kinds of things, right?
what about exercise?
Exercise sometimes can trigger MCAS.
So that's not what I wanted to hear.
I know. So you have to gradually, just like with POTS.
Movement. Actually, I shouldn't say exercise. I actually try and to steer people towards movement.
Yeah, movement I think is important, but I think depending on what your MCAS is triggered by. Okay. So, but I do tell people, a lot of people get like hives with running or a rash when they exercise or itching, right? That's a mast cell mediated phenomenon. And actually I've been asked to talk about this at a conference in September, the mast cell conference, which everyone should come to. It's in Minnesota.
I need to come.
Yeah. It's going to be fabulous, okay? But I'm giving a talk on exercising with MCAS. And there are some tricks. One of them is taking diamine oxidase, which is an enzyme you can take that digests histamine in your GI tract. Some people are actually deficient and really need this supplement.
So this is DAO, is that right?
DAO.
I've heard of this, but never used
when you exercise, you release histamine into your gut. And so if you're reabsorbing it, then you develop hives or rash or whatever. And so if you take the DAO before and it digests the histamine so it can't get reabsorbed, then you eliminate that exercise-induced symptom, right? Or if you take a Claritin before your exercise or whatever also.
So does this contribute to fatigue and post-exercise malaise as well?
That's a good question. I think a lot of post-exertional malaise has to do with MCAS, yes. And I think I have a lot of patients who, when I first started treating patients for MCAS in the kind of peri-COVID era, so it was patient after patient that would come back and say, like, my fatigue is better, my brain fog is better, and so I think MCAS definitely drives those things in addition to many other things, right? Like a lot of chronic fatigue and PEM is a lack of blood flow to the brain. That's clear. We have a lot of data to support that. So there are a lot of different factors, right?
I'm hogging the microphone.
But you were asking about, lifestyle modifications for MCAS and kind of what you can do. And I think it comes down to calming everything down and then slowly reintroducing maybe the triggers that were causing your symptoms before. As your body resets, then you can slowly kind of bring back things.
So, I like that we've sort of touched on that because I think it gives people hope because,
you're not on all this stuff forever.
Yeah.
No, I think you can. I think once you understand what your body's doing, once you kind of get better and you're feeling better, you can, your body kind of is less reactive. It doesn't respond the same way it was responding before. You're not in that heightened kind of fight, flight, like area, you're...
And I just want to touch on that. That's probably a good segue because there's one thing that I just can't let you leave without talking about because there was this amazing slide that you had up around like anxiety symptoms and the physiological symptoms of, between healthy people and people with I think
COPD and POTS.
And it's just that whole label that, you're not anxious, like these are physiological things that are happening.
100%.
Can you explain that slide and how that...
So there was a study done in 2002 that looked at patients with POTS versus healthy controls and patients with COPD and heart failure. And they were looking at quality of life scores. And it's very clear that the patients with POTS have a similar quality of life as those with COPD and heart failure, not normal healthy controls. But in the category of functionality that's based off of emotional circumstances, like your emotional functional status, the POTS patients were actually almost the same as the healthy controls, and the COPD and the heart failure patients were down real low. And then if you looked at role limitations, it's role limitations due to emotional versus role limitations due to physical inabilities, the POTS patients were the same as the heart failure and the COPD patients. And that just, in my mind, solidifies the fact that this is not an emotionally driven problem. Patients don't have POTS because they're hysterical. They have POTS because they have all this other stuff that we've just talked about, And so we all need to be very careful in saying, that this is an anxiety-driven problem. Now, that's not to say that there isn't a disorder of the limbic system, post-traumatic stress, correcting your mind, body, homeostasis. These are all very important things to help dampen down your sympathetic nervous system, increase your parasympathetic drive, and help stabilize everything. There is a psychological component, but it's not primary.
Yeah.
Dr. Alexis Cutchens, we could keep you in here for hours, but I'm pretty sure you need to get back to the conference and enjoy the rest of your time in Australia. I have had the best hour and a bit talking to you. Thank you so much for your time. You are changing lives, changing paradigms, not just in your clinic, but globally, I'm sure. And you're certainly helping me and us in how we manage patients who are so needful of improved management. So thank you so much. Thank you so much for your time.
I'm happy to have the conversation again. If there's stuff we didn't get to, we can certainly do another round.
We would love to. We would love to. Thank you so much.
You're welcome.